I'm one of the members of the Society of Pediatric Echo Education Committee, and we would like to welcome you all tonight for our second speed date. Tonight, our topic is on COVID-19 and the heart, and it's a special speed date where we will be doing Journal Club with Nadine Schreiter as will present one of the papers, and Simon Lee will be presenting the other journal. I am honored to introduce Dr. Kevin Friedman, who is my co-moderator. Dr. Kevin Friedman is a pediatric and fetal cardiologist and associate professor at the Boston Children's Hospital, where he's also currently the associate director of fetal cardiology. He's also the director of the Echo Core Lab for the Music Study, which is a longitudinal study on the cardiac involvement in multisystem inflammatory syndrome in children in MISC. So Dr. Friedman, it's an honor to co-moderate the SPEED webinar with you.
Thanks, Jen. I'm going to start by introducing Nadine Schreiter. She's going to present the first study. The first study was from the CHOP group and published in JACC last year in 2000, is titled Multisystem Inflammatory Syndrome Echo Findings in Children. Dr. Schreiter is the associate professor at Albert Einstein Medical School and director of the Echo Non-Invasive Division at Montefiore Children's Hospital. She's published extensively on Kawasaki disease and MISC. And so let her take it away.
Thank you for the organizing committee for inviting me. And I have no disclosures. I'd like to start by going over the MSc timeline. So April 26 to 27 of last year, a month after the COVID-19 peak, there was a UK alert for disease in children that was overlapping with Kawasaki disease and toxic shock syndrome. And at that time, it was known as pediatric multi-system inflammatory syndrome, closely associated or temporally associated with COVID-19. A week later, similar cases were reported in New York City. Following that, the CDC reported a case definition of that condition and coined the term MISC, or multi-system inflammatory syndrome in children. And then June and July of that year, several studies came about describing the acute presentation of MIS-C and reporting on ventricular dysfunction, coronary artery dilation, and elevated cardiac enzymes. And I've highlighted some of those larger studies. Yet most of these studies focused on conventional parameters of ventricular function or on qualitative assessment. And as you know, deformation parameters are sensitive tools to detect subtle changes in myocardial function. So the group at CHOP decided to describe the anatomic and functional echo manifestation of MIS-C disease in children. And their hypothesis was that MIS-C may be associated with reduced systolic and diastolic function, similar to other forms of viral myocarditis, and may produce dilatation of coronary arteries, similar to Kawasaki disease. So this was a retrospective single center review, again at CHOP. They looked at 28 MIS-C patients who presented between April and June of 2020, who fit the CDC case definition and were either SARS-CoV-2 PCR or IgG positive. They compared those to classic Kawasaki disease patients, 20 of those patients who presented consecutively in the year before pre-pandemic, and also compared those to 20 patients who were considered controls who presented for chest pain and murmurs, yet did not have echo abnormalities, also pre-pandemic. And they further divided the MIS-C group into those 28 patients into those who presented with a KD-like presentation, or 5 of those patients, and the majority presented in shock. They excluded those with underlying cardiac disease, ARDS, who required ECMO or had prior chemotherapy. They further divided those MIS-C patients into those who had myocardial injury, i.e. those who had increased BNP and troponin I, or those who had no myocardial injury. And that was their definition at the time for myocardial injury in the absence of a biopsy and the myocardial biopsy or MRI. They further divided the group into those with preserved left ventricular ejection fraction above or equal to 55% or impaired left ventricular ejection fraction less than 55%. So when they looked at their echoes, they looked at their echoes during the acute phase in the MIS-C and Kawasaki patients, and what they considered the subacute period in the MIS-C patients in 20 out of the 28 patients. And the majority of those echoes, or the initial echoes, were prior to IVIG. They defined coronary artery lesions as dilated if the Z-scores were more than 2, and aneurysmal if it was more than or equal to 2.5. They used the Boston Z-score system. And the coronary arteries were evaluated by 2 investigators blinded to the clinical data. They looked at conventional parameters of ventricular function, such as left ventricular ejection fraction, tissue Doppler, TAPSE, and mitral valve over A. And then they looked at speckle tracking parameter using vendor-independent software, such as Tomtec. They looked at the peak global longitudinal strain, which was an average from the longitudinal strain in both the 4-chamber, the 3-chamber, and the 2-chamber, the global longitudinal strain rate, and the early diastolic strain rate, the longitudinal early diastolic strain rate. They looked at the circumferential strain and strain rate, and the circumferential early diastolic strain rate. They looked at the peak global left atrial strain, which is a new method and a new tool that has been described in adults and is currently being described in children, mainly in hypertrophic cardiomyopathy, looking at peak global left atrial strain as a measure of diastolic function. And they looked at the peak longitudinal strain of the right ventricular free wall. So looking at the patients, they compared the MIS-C versus KD versus controlled using the Kruskal-Wallis test, and they did pairwise comparison using a Steele-Dwas test. And what you can see from this table is that the MIS-C patients were older than the Kawasaki disease patients, similar to other prior studies, and they were also larger in stature. Actually, more than 50% of the MIS-C patients were obese based on the WHO definition. When they looked at the coronary arteries, there was only one patient in the MIS-C group with coronary artery dilation, and that was a patient with a mildly dilated right coronary artery that resolved on follow-up, but they reported no segmental aneurysm and no new lesions on follow-up, as opposed to their classic Kawasaki disease patients who had 4 out of their 20 patients had coronary artery lesions, and 2 of those had segmental aneurysms. Yet we have to interpret that data with the MIS-C patients with caution, given the small sample size. Looking at conventional parameters of ventricular function between the 3 groups, what we find is that mitral regurgitation was more common in the MIS-C patients compared to the controls. The ejection fraction in the MIS-C patient was less than that of the controls on the classic Kawasaki disease. Also, those MIS-C patients had more pleural effusions. There was no statistical analysis performed on the conventional diastolic parameters between the MIS-C patients and the classic KD because of the big difference in the age between the 2 groups. So looking at the deformation parameters, whether it's global longitudinal strain, strain rate, or the longitudinal and diastolic strain rate, or the left atrial strain on those box plots where the MIS-C patients are represented by gray, you find that compared with the normal group, those MIS-C patients showed both left ventricular systolic and diastolic dysfunction using all those deformation parameters. And what was also found is that in the MIS-C patients with suspected myocardial injury, these were more affected than those with negative or no myocardial injury with respect to all those functional parameters. The authors, using logistic regressions for each echo parameter of interest adjusted by age and sex, found that the strongest predictors associated with myocardial injury in the MIS-C patients were the global longitudinal strain, the global circumferential strain, the left atrial strain, and the RV free wall longitudinal strain. Looking at the MIS-C patients with preserved function versus those with impaired function, what you see is that even though there was a group with preserved LVEF, they still had systolic and diastolic deformation parameters that were actually abnormal. And so here you see the systolic deformation parameters. Then you also see, even within the conventional diastolic parameters, that those with preserved function had abnormal diastolic function, as well as looking at the diastolic deformation parameters. So on follow-up, within 5 days, plus or minus 3 days, the left ventricular ejection fraction normalized in the majority of these patients. Yet what you can see from the graph A on top, the GLS remained low. And they used an average of -20 based on prior published data of normative values as their cutoff. And most of these patients had a GLS that was high, that was higher than -20. The diastolic dysfunction also persisted, and not shown here, the right ventricular free wall longitudinal strain also remained low. And then they correlated between the clinical labs and the echo data using Spearman rank order correlation test. And they found that the global longitudinal strain, the global circumferential strain rate, and more importantly, the left atrial strain and the right ventricular free wall longitudinal strain showed the most significant correlation with the BNP and the troponin level. So in summary, this study provides and emphasizes the importance of comprehensive echo assessment of myocardial function in MIS-C at a time where we were performing very fast echoes, meaning they were short, they answered the clinical question, and we were out of the room. The authors found that MIS-C versus Kawasaki disease had a lower ejection fraction, yet more strikingly had lower global longitudinal strain and strain rate and worse RV systolic function. And they found that the parameters of diastolic function, conventional or not, were worse in the MIS-C versus Kawasaki disease and controls. And even though conventional markers of systolic function normalized, global longitudinal strain and diastolic dysfunction persisted. Yet we need to interpret this with caution given the small sample size and also the short follow-up period, especially now that we have 6 months data on these patients out. And also at the time the paper was published, we had limited cardiac MR data to assess for the health of the myocardium. Since then, there were small studies looking at MRI in the acute period that showed late gadolinium enhancement in 10 to 20% of those patients. And also in most of the studies that have been published in the 2 to 6 month period, no late gadolinium enhancement was found. I'm happy to hear from others if they've seen something different. In addition, the coronary artery changes were reported at 4% in this study. Yet again, this was a small sample size, and larger studies using the same nomenclature of coronary artery dilation reported anywhere between 9 to 20% in the acute period. So thank you for listening, and I'm happy to answer any questions.
Thanks, Nadine, for that very comprehensive review of that article. One of the lessons or things I learned from that article is if you look hard enough, you will find abnormalities in these patients, and virtually all of them. And I think that was what this really highlighted. Are there any questions from the audience? I do have a question, which is more related to how we interpret this data and follow up, because we're certainly seeing that if you look hard enough, you find abnormalities, but what they mean over time is hard. What is I know you've led your center's effort in this. What is your center doing longitudinally in terms of following these patients up now that we're over a year out?
So that's a good question. So initially we were following them very closely. I think like everybody else, a week, a month, 6 months, and now we're gone to the 1 year follow-up. And we are, in addition to conventional ventricular function parameters, we have looked at strain. We have seen similar findings. We have done cardiac MRs on those who had ventricular dysfunction and who could sit through the scanner without the need for sedation. And we haven't seen any evidence of fibrosis on late gadolinium enhancement or on T1 mapping. We have exercise tested them. These were normal. We actually had one patient who actually showed up with ventricular arrhythmia on a Holter monitor in the follow-up period. So of a week after follow-up, but we haven't seen any other abnormalities. So clinically, they seem to be doing well, as you know, they seem to be doing well. The question is what to do with the findings that we're seeing on echo.
Great, thank you. I think in the interest of time, we'll move on to the second article.
All right, our second article is on the echocardiographic indicators associated with adverse clinical course and cardiac sequelae in multisystem inflammatory syndrome in children with coronavirus disease 2019, which is a manuscript from Detroit, published at JACE in 2021, and will be presented by Dr. Simon Lee, who is an assistant professor of pediatrics at the Ohio State College of Medicine and currently part of the Heart Center at Nationwide Children's Hospital. He's also the director of the Coronary Anomaly Program and the Kawasaki Disease Program, and leads the COVID-19 response team for cardiology at the Nationwide Children's Hospital. So his clinical interest focus is currently on to evaluate myocardial injury in COVID-19, MISC, and also heart transplantation. So without further ado, Dr. Lee, take it away.
Thank you, and thanks. I just wanted to thank the organizers for inviting me to talk. Glad you got through that, Jen. It sounded like it was a little wild, the background there. So I'm going to be presenting this article. Like Jen mentioned, it's a long title, which I feel like all of these MISC articles have very long titles because just the disease process is about 7 words. So Nadine gave a great introduction to MISC, and so some of this will be a little bit redundant, so I apologize for that. Since the initial description of MISC, or PMIS as it was called, from the UK, there have been 5,217 cases of MISC reported in the US. And fortunately, only 46 MISC deaths have been reported, which has been rare, equaling a mortality rate of about 0.8%. We here in Ohio, of course, doing our part to add to the case mix here. We've got 200 to 249. And by color shading, we're trying to catch up to some of the big boys like Florida and Texas over there. Many of these patients present acutely ill, and this is some data from the US multi-center surveillance study by Sun et al. And what they found was that of this large cohort, there were 74% who required ICU admission, 47% who required vasopressor support, 3% who also went on to need ECMO support. In addition, in this large group, about 50% of the patients had an abnormal troponin level, and about 41% of those patients had ventricular dysfunction on presentation, which I'm sure is very similar to the experience that a lot of you all have had. But despite the acuity of their illness, how sick they are, and the type of resuscitation they might need, there's actually remarkable recovery that's made after treatment. This is another paper from that same group by Feldstein et al. And from this paper, what they found is that 91% of the patients had a normal LVEF by 30 days out from hospitalization. So this kind of leads to the question of what the long-term morbidity to the myocardium is. And as Nadine was mentioning, strain imaging is a technique that measures deformation, or the change in thickness and length of contracting muscle. And it's been shown to be a sensitive marker for evaluation of ventricular function, as well as being able to detect early abnormalities in the heart muscle. So our study today from Sunil et al. Looks at the longitudinal strain imaging in MISC patients, as well as reporting their findings on some short-term follow-up. So the aims of the study were to evaluate echocardiographic measures of ventricular function, including longitudinal strain, to risk stratify MISC patients for adverse clinical course and cardiac sequelae after discharge. This was a retrospective observational cohort study as a single center, as was mentioned previously. They included all consecutive cases of MISC that met the CDC case definition from March 2020 to January 2021. They admitted 54 patients and had baseline data, including clinical information, echo data on these 54 patients. And then going on to their follow-up group, they had 32 patients that completed all of the predetermined follow-up for the study, which was the 3-week visit and the 10-week visit, as well as an additional 4 patients that had the 10-week follow-up visit but missed the 3-week visit. TTE was, in terms of their echo protocol, TTE was performed on admission and then on discharge in a select number of patients. And then they also had the 3-week post-discharge and the 10-week post-discharge echo. Strain was analyzed retrospectively via TomTec. They looked at the left ventricular apical 4-chamber view longitudinal strain, or 4-chamber longitudinal strain. They were able to obtain in all of the patients on their admission data, as well as all of their follow-up imaging. They also looked at a single slice LV circumferential strain at the level of the papillary muscles from parasternal short axis. They did look at left ventricular global longitudinal strain, which is the triplane strain, getting longitudinal strain in the 4, 3, and 2 chamber, but they were only able to obtain global longitudinal strain in 39 of the 54 patients on admission due to limited apical 2 and 3 chamber views. And they talk about this a little bit in, which is the experience that many of us had early on in the pandemic, where many of the images in the beginning, sonographers were just trying to get in, do quick function evaluations and get out to minimize exposure. But because only 39 of the 54 patients had the global longitudinal strain, majority of their analysis was done using just that single plane apical 4-chamber longitudinal strain. They did compare strain parameters to an outpatient age and sex matched control group. They had a 2-to-1 ratio of controls to cases. These are all patients that had normal transthoracic echocardiograms for an indication of murmur or chest pain. And then they also did do inter and intra-observer variability and reproducibility. So part of the reason why they did most of the analysis in the apical 4-chamber longitudinal strain was that when they did a comparison of the apical 4 versus the global longitudinal strain in the MISC patients that had both, the authors didn't find a significant difference between the two. And so that was part of the justification for doing the majority of the analysis with just the single plane. From that single plane, so the apical 4 longitudinal strain, they divided that cohort into tertiles for comparison's sake. They did also divide the groups into tertiles by LVEF and also by the global longitudinal strain, which again was only 39 patients. And all of that data was included in the supplemental data. They took these tertiles, those 3 groups, and compared the clinical variables between the 3 groups. So here you can see, that this was the lowest, and then here's the middle, and then again the highest group. So when looking at their patient population, overall, they found that those in the lowest tertile for the longitudinal strain were older, had higher peak CRP and higher peak high sensitivity troponin. And that's pretty consistent with what's been reported in other studies, that older patients with MIS-C tend to be sicker. Here, looking at some of the other clinical variables, this again kind of shows similar findings of sicker patients in the lowest tertile with longer ICU stay, longer overall hospital course, and then also more of these patients requiring inotropic support. And then they did include the 4 patients who they went on to put onto ECMO, which of course were the lowest tertile, which makes sense. So while they found that strain improved over time in the entire cohort, the group in the lowest tertile actually had lower strain at the 10-week visit compared to the other 2 tertiles, with the mean strain of the lowest tertile being 18.5%. And again, they just reported the absolute number. For longitudinal strain, it should be negative numbers or negative percentages. So 18.5% was the mean for the 10-week follow-up versus 21.3 and 20.9 for the other 2 tertiles. They also found that the lowest tertile group was the only one that still had patients below the normal cutoff of 19%. That minus 19% cutoff was derived from their control group, which I'll show a little bit of data towards the end. But that was basically the lower limit of normal that they came up with from their control data. And you could see that out of the 14 patients in the lowest tertile group that had 10-week follow-up, half of them still had what would be abnormal strain based on their control data. Otherwise, when you compare it to the other two tertiles in the middle and the upper, you can see that none of those patients had longitudinal strain below 19%. There were some circumferential strain abnormalities that were noted. Again, this is just a single slice in the mid-level. You can see that it was lower in the lowest tertile group on the initial presentation compared to the mid and the highest, but that those differences resolved by the 3-week visit. And what's really striking to me about this data and what was really interesting to me was that what's been reported in the prior study and as our personal experiences have been, even though we still see strain abnormalities in this 10-week follow-up, all of their ejection fractions are normal. And you can see that even by pre-discharge, all of these patients had an ejection fraction, LV ejection fraction of about 62% on average. And then over the serial follow-ups, at 3-week follow-up and 10-week follow-up, you can see that these ejection fractions remain in the 60s. And they did have one patient with an abnormal ejection fraction at the 10-week visit in this lowest tertile, but in the paper, they said that that actually was just 54%. So I wouldn't be surprised if they interpreted that as normal function, despite having all these strain abnormalities. And so this is just a box whisker plot from that paper showing the higher peak high sensitivity troponin level. You can see pretty significantly higher compared to the other two tertiles. And then this was the box whisker plot. This is actually in the supplemental data. If you guys looked at the paper and you couldn't find this, I don't know why it was in the supplemental data because I think this is really a fascinating figure. This looking at the box whisker plot for the longitudinal strain, again, just the apical 4 longitudinal strain over on admission, and then at the 3-week follow-up, and then the 10-week follow-up visit. And in the lowest tertile, you can see this dashed line represents minus 19%. So that would be what their normal cutoff was. And you could see that there's still a significant number of patients below that normal cutoff in the lowest tertile compared to the mid and the highest tertile. You can see that everybody was above this 19% cutoff. And then just to show everyone, this is the control data that they had. This was again matched, age and sex matched to the MISC group, 2-to-1 ratio. So 54 MISC patients, 108 controls. And this was the apical 4 longitudinal strain data that they got. So they just took the mean and plus 2 standard deviations, or I guess minus 2 standard deviations to get to the minus 19% number. So in conclusion, patients with worse strain on admission were more likely to have hypertension, acute myocardial injury, require inotropic support, have cardiogenic shock, require ECMO, and have a longer hospital length of stay, as well as PICU length of stay. Their LV apical 4-chamber strain remained reduced in a subset of patients as late as 10 weeks post-discharge, despite all having normalized ejection fraction. And longitudinal follow-up, of course, is needed to see if these strain abnormalities resolve. Thank you very much.
Thank you, Simon, for such a wonderful presentation and really comprehensive. Are there any questions? You can type on the chat box or unmute yourselves. If there are no questions, I have a question also for Nadine and maybe Kevin. So I know that we did, and for both of these, with both of these manuscripts, they routinely do strain on MISC. Do you guys routinely do strain on your acute COVID patients as well?
We do get strain. I'm always harping on our sonographers to get strain, and they always do a great job. But we actually encounter a lot of the similar difficulties of just, you know, sometimes these kids are pretty sick when they get their initial echo, and so it's hard to position them. And so we usually are able to get apical 4, but when we went back to try to analyze, or we actually use we use an auto strain on the Philips Epic, and for the 3 and the 2-chamber have been kind of difficult to get. But we also actually, we do a lot more CMR in these patients. And so we've been getting CMR on all of the patients that can get it without sedation, who had either troponin elevation or dysfunction. And, you know, we have MR strain actually pretty far out now. Like we're starting to scan some of these patients about a year out, and definitely everybody as far out as 3 months on their CMR strain by strain encoding have had like markedly diminished strain. So we kind of use a combination of echo and MRI, although I'd say we probably more reliably get MRI strain.
Right, Nadine?
So on the COVID-19 patients, especially in the acute phase, we don't usually get it, especially that I wouldn't say we don't get it. We always try, but the issue is with these patients is often our patients are obese. The acoustic windows are difficult, so we haven't been very successful at getting it. On subsequent studies, if patient permits, part of our protocol is to get strain imaging.
Us here too, you have since ever since all of our echosonographers have been vaccinated, we have asked for them to do strain on even acute patients, acute COVID patients. Kevin?
We generally have not because of exposure. In the acute COVID patients, we've tried to keep it really focused just for sonographer exposure, but have done that routinely in the MSC patients.
Good. So there are a few questions on the chat box. From Kirsten Dummer, was obesity a risk factor for abnormal strain?
So part of the issue with this paper and some of the other papers is that there's such a wide range of the ages, and they don't necessarily give you the percentile. But it did seem like, at least on the other papers, just in general, that obesity was a risk factor for more severe more severe MISC. So I'd imagine, it seems like these strain abnormalities are tracking with the severity of their illness. So I'd imagine that would be the case, but at least for the paper that I presented, they didn't give you percentiles, and they had kind of a wide range of ages. So they didn't address that specifically.
So go ahead.
Oh, no, I was just going to say in the paper I reviewed, more than 50% of these MIS-C patients were obese. So it's hard to make that conclusion.
Right. So one from Dr. Annette Ansong, thoughts on why strain remained abnormal, though EF was normal in some of these patients?
So it's really interesting, actually, because we've been, at one point, we were doing a lot of MRIs on our COVID positive athletes, screening for myocarditis. And a lot of them, even though they were not hospitalized, had pretty significant strain abnormalities. Like we had actually done an MRI on 130 adolescent athletes, like non-hospitalized, and they had pretty significant strain abnormalities across the board. So some of this, I think, is related to just SARS-CoV-2. There's definitely a lot of evidence that there's just direct cardiotropism with SARS-CoV-2 in the myocardium. So I think there's some of that. But I also do think that, it's kind of amazing just to imagine that somebody could be that sick and have no abnormalities whatsoever by the time they go home. Like we had a patient who, was placed on ECMO, which I'm sure many of you guys have had that experience. Placed on ECMO, EF was like 27%, got decannulated, hospital length of stay was 13 days, walked out of the hospital, their discharge echo had an EF of 65. I just find it kind of hard to believe that you could have that kind of insult and not have some sort of, I find it more interesting that the EF is totally normal after they're that sick. So to a certain extent, I don't find the strain abnormalities that unusual. I just am more interested to see if they resolve over time.
All right, one last question from the chat box. Has strain abnormalities changed your approach? More rigorous follow-up, further imaging, activity restrictions?
Nadine, do you want to answer that one? Or?
Sure. I would say not really. I'm just going to be very honest about that. Because the thing is, we have done cardiac MRs in those with ventricular dysfunction or those who had evidence of myocardial injury. And in our center, at least on follow-up, we have not seen, we didn't do strain MR, but we haven't seen evidence of fibrosis. We have stress tested them and we haven't seen anything concerning. So we haven't been restricting based on, I would say, other abnormalities.
All right. Well, thank you, Nadine and Simon and Kevin for co-moderating. Great presentations for tonight. On behalf of the Society of Pediatric Echo Education Committee, we would like to invite you to our next SPEED webinar. It's going to be on not the 4th Tuesday, but on November 30, and it will be a how-to series, a how-to screen for cardiomyopathy. So that should be very interesting. So see you all on our next SPEED webinar on November 30. Thank you so much, everybody. Good night.
Thank you. Thanks for having us again.
Thanks, Nadine and Simon.
Thank you. Thank you all.
Great job.
Congratulations, everybody. Good
Thank
night.
you. Bye.
Thanks. Good night.
Bye.